So I'm assuming everyone can hear me okay, is that correct?
Mm-hmm.
Okay.
Loretta, this is Linda. I would just be a little bit louder.
Yeah, a little bit louder.
Okay. So the issues and challenges I'm going to talk about today is terminology, implementation strategies, context, and sustainability. The ones that are in brackets are the ones I am not going to talk about, but certainly could actually answer questions when we get to the discussion about these areas. So my comments today are really based on my experience in conducting implementation studies as a PI and participating in funded centers. I've also done a fair amount of review of the science and implementation, and I wanted to point out two resource texts that are very recent that are very valuable. Many of you know already, but there are at least 100 different terms that we use to talk about translation and implementation science and all the related language. Knowledge translation, translation research, knowledge to action, evidence-based practice in comparison to evidence-informed practice. And even across disciplines, the term translation science differs. So if you're talking to a bench scientist, it really means how do I take my bench research findings and turn them into a clinical trial. People who have done efficacy studies and have had very positive findings in a number of areas are interested in translating or implementing those findings into clinical or public health practice. So this diversity of terms really does impede our science of translation, because when you go to do a search, you have to use a number of various search terms. It's really hard to synthesize and apply research findings across studies. So for example, if you want to do a synthesis on opinion leadership, you also include those studies that have been done on knowledge brokers, which are very similar to opinion leaders. It also makes it difficult to collaborate across geographic boundaries and disciplines, and it challenges our ability, I think, to learn from investigators amongst ourselves, but also in other disciplines. I want to make sure that we understand the difference between the clinical intervention and the implementation intervention. In the clinical intervention is the evidence-based program or practice as actually you're promoting uptake for. For example, FOCUS is a psychoeducational didactic intervention for adults with cancer and their loved ones, family member, and we have worked to implement that in the cancer and support communities, but the intervention or program is the FOCUS program. The implementation interventions are strategies that you really use in tests to promote uptake of evidence-based practice or program, and that can be things such as audit and feedback and quick reference guides. I think we also need to make the distinction between evidence-based practice and translation science. They're not interchangeable terms. Evidence-based practice is a type of quality improvement, and it is the doing of or applying in practice to improve health outcomes. Translation science is conduct of research. It's also known as implementation science. So I've put two slides in here on definitions. Some of you probably don't need those, but here's the definition of evidence-based practice, and one on implementation science. And I will tell you that explaining or the mechanisms by which the implementation interventions or strategies work is a really important part of implementation science. So in terms of strategies with implementation, in terms of challenges with implementation strategies, I'm going to quickly review what we know in terms of what is an implementation strategy, the challenges with naming, defining, and the taxonomic structure, selecting and testing implementation strategies, and then describing them. So what are implementation strategies? They are really methods or actions by which we promote uptake of evidence-based programs or practices. You can have a discrete implementation strategy such as one action. Audit and feedback would be an example. You can have multifaceted implementation strategies comprised of 2 or more discrete strategies, such as audit and feedback and opinion leadership. Some people also call implementation strategies that are multifaceted implementation interventions. But when you think about these are really process interventions, and they are, by definition of Craig and all, complex. In terms of naming, defining, and the taxonomic structure, this is what I would call a gnarly issue. The Cochrane collaboration, the EPOC group, has somewhat of a taxonomy and has a naming for those implementation strategies. Locher and al. Did a scoping review of classification schemas and found 51 diverse classification schemes to cluster what we call implementation strategies. Mitchell and al. Has worked over several studies and has a behavior change technique taxonomy, which is version 1.0. And in their work, they identified from the literature and from studies 93 implementation interventions and clustered them into 16 categories. I will tell you that this has been applied by several implementation scientists. And that's a lot of feedback. Is called the ERIC project, that stands for Expert Recommendations for Implementing Change. Together, 71 experts. Somebody's feedback, so could you put your phone on mute, please, or your microphone on mute? Thank you. So, they brought together 71 experts with research expertise and also practice expertise, and about 97% of them were from the VA, from the U.S. and from the Veterans Health Administration. And through a 3-round modified Delphi process and majority consensus, they listed and defined 73 discrete strategies, and then clustered them into about 6 categories. Now, I am going to do a little bit of a critique of this work in that when I look at this work, there's huge variation in naming of the implementation strategies in terms of conceptual levels. So things like facilitation is an implementation strategy. That's a pretty high-level concept as compared to audit and feedback. And to date, this taxonomy and definitions has not really been accepted broadly by the translation community or tried for application. And there are other competing taxonomic structures that have been suggested from the synthesis of the research. And so I think there does need to be some review and refinement of ERIC from other stakeholder groups. And it would really be a major undertaking, but really would be important to look across these taxonomies for comparison of names, definitions, and see how they're similar or different, and also the clustering, the categories that they're put in. In terms of selection and testing of implementation strategies, that should really be guided by a scientific framework or a theory, framework of implementation science. And that's because factors do influence implementation, and often you can tease those out of the framework. And then based on results, the framework can be revised. And the framework you'd select, of which there are many, needs to be based on the aims and scope of your study. So, for example, if you're trying to implement something in public health across multiple sites, you might want to use Glasgow's REAIM framework. So the use of the framework should also help us in understanding our mechanisms and advance the science of implementation. So Burkett et al. Did this study in which she surveyed 223 implementation scientists across 12 countries, and she found that they were using 100 different theories that span multiple disciplines. The most commonly used are listed on this slide: SIFRI, REAIM, Diffusion of Innovations, and the Theoretical Domains Framework. Tinkle and colleagues looked at studies that were done between 2005 and 2012 in the dissemination implementation NIH-funded studies from R01s, and found that less than half used a theoretical framework. I do think that's getting better. And there's several experts that have reviewed the literature and studies and found that the frameworks are used somewhat superficially or misused. They might be mentioned at the start of the study but aren't really integrated throughout. Clearly emerging from this field is the importance of understanding the mechanisms by which implementation strategies work. Why do they work in some settings and not others? How do they exert their effects? What are the moderators and mediators of the effectiveness of these implementation strategies that are being tested? Craig and all really advocate doing a process of evaluation alongside the trial so there's better understanding of the mechanisms, and then using a mixed methods approach is important. Another area is that implementation outcomes, fairly new in the D&I research world, are looking at implementation outcomes that are proximal to the health outcomes. So one example might be fidelity to the implementation strategies. And the rationale is to differentiate between, we have implementation failure, in other words, those strategies not being used, or is the evidence-based intervention or program ineffective in the new setting. In terms of documenting components of the implementation strategy, excuse me, first of all, it's important to name it and use existing terminology and define that strategy conceptually. So what is audit and feedback, for example? And then operationalizing it, who is delivering the implementation strategy? What are the action steps in the process? So for audit and feedback, it may be one investigator or one person internally, like the opinion leader delivering audit and feedback, so you need to say that. What are the steps in doing the audit and feedback process? Who's the action target? So who are you targeting the audit and feedback reports to? Nurses and physicians, nurses, consumers. And then where in the sequence of things that are being done for implementation does this strategy fall? For example, an audit and feedback might occur after education and after performance gap assessment shared with the community. And then this whole concept of dose, which has been written about for some time now, is how much of the implementation strategy are you using? So if you're doing audit and feedback, how many times are you doing audit and feedback? So, for example, in one study, we did audit and feedback every 6 weeks for 5 sessions, and each session took about 30 to 45 minutes. And then looking at what are the outcomes to be affected and to have some kind of justification for the implementation strategy. So here's some just basic principles. I won't spend a lot of time on this slide, but it's really important to know where implementation phase of your study starts overall in terms of the entire study time frame, and then when does it stop. And then you should also be tracking fidelity to your implementation strategies. Context is, there's multiple definitions on this slide. The last one by May and colleagues in 2016 is the one that is emerging in terms of really being important for implementation science. So the recommendations are really to define context as the environment in which implementation is taking place, and that can be characterized by structural factors like the type of environment, staffing, the social dynamic factors, the relationships in which people work, and then the external factors such as the Joint Commission regulations. The challenge with this is what to really measure. So, for example, the implementation climate scale looks at staff perceptions, and in which there's priority setting and valuing for evidence-based practice. The implementation leadership scale looks at staff perceptions regarding the extent to which the leaders enact behaviors that support evidence-based practice. The implementation citizenship behavior scale, which is newer than the other two, looks at behaviors by employees that exceed their job expectations to support implementation. Mid-level managers, competency scales, and then structural factors such as staffing, patient volume, and type of setting. The other challenge here is when do you measure this? How often do you measure them? And do you hypothesize whether they're mediating variables or moderating variables? And then lastly is the challenge of sustainability. Again, the last bullet on this slide is the one that is probably the most defined at the moment. There is not a common definition of sustainability. I do have a list of references on the last slide, and I put a couple there about sustainability in which they actually are looking at definitions. But are the evidence-based practices continuing following the implementation phase? The other challenges are who's responsible for sustainability planning. When you're an investigative team and working with stakeholder groups, do you do that? I would suggest you do that engaged with one another. The other challenge is that grant funding doesn't really contain many incentives to study sustainability, and we need knowledge in this area. And then the other challenge is when you're measuring sustainability, do you measure the continued use of evidence-based practice, the outcomes, or the implementation strategies themselves, or all three? I think it's really important to plan for sustainability as part of implementation, and I've listed some suggestions here, as well as those not just mine, but from other investigators. And then make sure there are mechanisms for training of new staff. So in terms of opportunities, there's a new PAR out that came out in May for both RL1s, R21s, and RL3s. Pay particular attention to Section 5 because it's specific to the FOA. And there was a recent webinar, was it last week or this week, by NCI about this FOA. Two things I took away from that webinar is that they're really interested in implementation outcomes, and they don't want just testing of implementation strategies, they want understanding of the mechanisms. Here are some other places that there's opportunities for funding. We've had pilot monies from our CTSA for our focus implementation project, which was very helpful. Also partnering with investigators who have done efficacy studies to help with translation. In my opinion, we need many more training programs around implementation science. There's great opportunity for methods research in this field as well. So in summary, I've discussed some issues in implementation. There's many others that I haven't discussed today. I've overviewed some opportunity, and nurse scientists can lead in addressing these challenges. So thank you for your participation. I look forward to our discussion. And here are some selected references on the next slide, which I know you probably can't read, but you will be getting these slides. So thank you very much. So now I need some guidance on what I should do. I'm going to stop sharing. Hello? Hello, am I the only one talking?
I think Kathleen has the ball now. Marina,
Okay.
thank you. Thank
Okay.
you.
Very well done. So, Linda, can you hear me? I'm audible.
I can hear you, but I can't see your slide.
Not a problem. We're going to go to those slides next, and want to say what a privilege it has been to share this panel with Dr. Titler and Dr. Roussel as okay, here we go. Now you should be able to see them.
We can. Thank you.
Okay, good. And for setting this up, and the idea of us having been pioneers in evidence-based practice, and then the idea of people like Dr. Roussel keeping us going, and Dr. Cohn keeping air beneath our wings to move in this very interesting wide plane of new science. We were back 20 years ago when evidence-based practice was new, and now we're in implementation science and research. So with that, I'm going to offer you not necessarily the pioneers covered wagon across the Wild West and the plains, but more or less a pony express that will reinforce some of the things that Dr. Titler has mentioned. So Marita has done a real good job of providing you some pointers of where to go next. It's a kind of a big gulp at this point. Earlier this
Kathleen,
yeah?
this is Linda. Can you put your slides? Can you, because all we see your slide panel for your slide and then the slide in the middle. But can you show the, it's the presenter's view? Because we can see the slides with the small. Yeah. We can see if you need to. The very bottom, the very bottom to the right-hand side, where you actually show the full slide. If you could do that, that'd be great.
Right, that's where we are. Sharing screen 2. So let me reboot this and see about opening this up. So I'm not using the presenter view.
Okay.
And this went so smoothly during rehearsal.
Mm-hmm.
That's what this is. Yeah. Okay, we're doing a check over here. Are you sharing? Uh-huh. Try this one.
Okay, we can see that in. Yeah. There we go. There it is.
Okay. Excellent. Thank you for that coaching, Linda.
Thank you.
So you're right. So what I wanted to do is share with you information that has really been collected through some activities through the Association for Clinical and Translational Science, which is a professional association that really is the meeting spot for clinical and translational science award people. So it's heavily interprofessional, and the Translational Science Conference is sponsored by ACTS, and this particular set of slides has been adapted from a panel that we presented. It was called the NIH Viewpoint on Implementation Science. The Galanetta is from the National Cancer Institute. The Patricia Jones is from the National Center for Advancing Translational Sciences. And Jonathan Tobin is also very well positioned within the CTSA colloquium but also he and I serve on the Journal for Clinical and Translational Science editorial board. I'm on the ACTS board of directors. Why is this important? This is so important because the idea is that this group of people are really driving implementation research, implementation science. In particular, Marita mentioned Russ Glasgow, and I consider him like the founder of implementation science when he stood up that center within the National Cancer Institute. So it was a privilege to serve with them on that panel in March and also to use some of their slides going forward. I think in a new field, it's really important to connect at the personal level and at the association level. So in thinking about where we might go is, first of all, I'm going to say nurses really are the core of any system, and the objective or the target for implementation research is to change the system. So I mentioned that CTSAs, there are 56 currently funded, and they have a unique interest in dissemination and implementation sciences. The ACTS now has this call for manuscripts and invite each of you to share in thinking about submitting to this. It's dissemination and implementation, and you'll see that these are separated in our call as separate sciences, dissemination and implementation sciences. So we'll see some of this thinking evolve and think about where nurses can put their shoulder to the wheel and help with this. So again, to look at this idea, Linda, can you see this phone thing? Maybe I can get it.
I can.
Okay, is it gone? Okay, good. So despite a surge of interest among health professionals and academic researchers in conducting investigations to move promising clinical interventions into routine practice, research methods unique to this science are new to many researchers and clinical partners. And so I think the timeliness of this topic is just amazing. The key points that I'll touch on, I call it teeing up. So there's theory, taxonomy, tools, teaming, and training. And it will reinforce and rephrase some of Marita's presentation. The first thing about